My name is Tracy Gardner, and I am the co-director of policy at the Legal Action Center. Many of you may know my other director, Gabrielle Della Gueriner. And Legal Action Center is the country's only law and policy advocacy organization that focuses on HIV, criminal justice, and addiction issues. And this goes right to our work as a direct legal services provider and policy advocacy. We have our Washington folks here today, Dan Belknap, many of you know, Mark O'Brien's around, and we are delighted to be able to work with the senators who've put together this forum. Addiction and its consequences have long been part of our 40-year history. And we are gratified and also exhausted over the opportunity that's abounds. So again, this panel is focusing on women, addiction, and motherhood. And it is not, as we focus on women and addiction and women's role as mothers, and it often defies rational thinking as we're trying to make good decisions to support women and in their special capacity as mothers. Identifying strategies that work, having to navigate silos, because it's not just ever about addiction. And for women in communities in particular, we are talking about multiple systems as were referred to before. For today, those systems aren't here, but we do need to keep them in mind because it will be one hand clapping unless we thoughtfully incorporate the other elements that affect women. And what I think also is going to be addressed, and we have been addressing, is that as the nature of addiction as a family disease, that we err greatly when we try to separate mother and children as if one's health and well-being is more paramount than the other. In this issue, as in many others, they are inextricably linked. And so we are going to talk about programs and approaches that acknowledge that very important, very critical issue. We have a stellar panel, and I'm going to trust that many people have received the information that's on the tables outside, and I won't embarrass the speakers too much with their illustrious bios. But it does look like we are going to be very thorough in this panel in having clinician and direct service provider and service provider in the intersection around criminal justice and women and addiction. And my special preference, not preference, but it's a delight to have an insurance company here. a payer. Don't throw your shoes. An enlightened one. We'll clone you afterward. Without further ado, and we are going to have questions, opportunity for questions afterward, and we are being taped. So there will be lots of bounce, I hope, from this. So without further ado, I'd like to introduce Andre Jones, Dr. Andre Jones, who's the executive director of UNC Horizons, and she is also a professor in obstetrics and gynecology at UNC School of Medicine. And she is going to talk to us about the clinical issues around treating pregnant and parenting women with substance use disorders. Dr. Jones?
Thank you so much to the senators and to the staffers for all of your work to put this together today. It is truly an honor to have the opportunity to be a small voice for the women of the North Carolina who really do have a lot of hope. What I'm going to share with you is one example of a treatment program that is working really well, that is truly dyad-centered. It focuses not just on the mom or on the child, but it's them together as a dyad, and where we say that we teach women and children to learn how to dance rather than how to wrestle and fight. So next slide, please. So this is our model and our approach to care. First and foremost, you have to have an excellent clinical care program. I'm going to tell you about the elements of that. Then I think that we also have to be training the next generation in what we're doing. So we have a huge commitment to training all of the learners, from undergraduate to medical professionals, dentists, social service people, everybody who law enforcement actually, every single person who might come in contact with a woman of childbearing age who's using substances. They need to understand how to identify substance use disorders and at least where to refer them for treatment. And they also have to understand that treatment works. Next slide. So these are the women that we serve, and we got to hear some voices of recovery in our first panel. Let me share with you the kind of a composite of the women that I serve. Almost all of the women that come to us have come to us because they are pregnant and they've been identified through Child Protective Services, or they come through drug court, or a family member calls on their behalf, or we get a provider that says, help me, I've got this woman, she's pregnant, I don't know what to do. And then we have the desperate women who are calling every single day. And if I could bring my case manager here to talk about that, she would say that the pain and suffering that she hears, she gets 25 to 30 calls a day, and we only have 16 beds in one unit for residential treatment, 8 beds in another, and we desperately need more opportunity and more resources to serve women. Most of our women do not have jobs, they do not have transportation, they don't have a driver's license, they have not been in the workforce, they've dropped out of high school, often because they've gotten pregnant. Almost all of our women that have come through have been physically, sexually, and emotionally abused. And if there's one policy thing that I really want to advocate for, is that we need to, as a nation, take childhood sexual abuse seriously, get it out into the light, shine light into it, and get really good prevention, because so many of our women, that's where the pain and the suffering started from with their before they went to their substance use disorder. Many of our women have been told by their parents that their body is their pocketbook, and the only thing you're good for is selling your body. That's the only way you're going to make money. And we also have higher rates of women who are coming in that are testing opioid positive. It used to be, when Horizon started in 1993, that they were all cocaine use disordered women. Now, a third of our women are prescription opioid using, and where they started getting it from their doctors, from their medicine cabinets in their homes or their family members, and a few of them buying it off the street. Next slide, please. So because there is this intersection of no employment, a lack of education, really high rates of physical, emotional, and sexual trauma, we have to have a complex treatment to treat these complex women. It is an unrealistic expectation to think that if we treat somebody for 12 weeks, they're magically going to get better. It took years for the addiction to get to this point. It's going to take equally years to help our women be in full recovery. So we provide trauma-informed care. We actually use a lot of Stephanie Covington's work, as well as Lisa Najavit's. And that's intertwined trauma and addiction treatment. We provide childcare. We are one of those programs, because thank you to the state of North Carolina and allocating their block grant funding appropriately to help us have childcare. That's fantastic. We have a maternal child therapist on site. We fund that position on a grant. It's a grant, the Orange County Partnership for Children, because we don't have any other resources to do that. We do provide opioid medications for our women who are opioid dependent and need them. So we use buprenorphine as our main modality of treatment. We also very much applaud the use of methadone when it's used in appropriate doses, just like buprenorphine. We have a big rehabilitation component, because our premise is you need to first become abstinent from drugs, you need a safe place to live, and you need to get gainful employment or fulfilling volunteerism, or get your GED that's going to lead to your future job, your now job, and then your future job. We also are unique in the fact that we have an OBGYN center where women can go and they can receive their OBGYN care. And we also have a nurse nurse on staff to provide that low-level medical care that our women and our children so desperately need. Next slide. So this slide is to tell you that treatment for pregnant and parenting women works, but it works not in a vacuum. It works by a whole group of community people coming together to help build community around our women. So what these slides shows you, these are outcomes from our women who were pregnant and went through our Horizons treatment. And what you can see is that in the 1.5 prematurity rate, so if you're a woman who has a baby at Horizons, you have only 1.5% of our babies are born premature. And that's actually better than the state average of North Carolina, and it's much better than the average of non-treated pregnant women. In terms of low birth weight, our babies also look better than the state average and another sample of untreated women. So this shows you treatment works for pregnant women in terms of birth outcomes. The other really good success story that we have is about child protective services. So women that complete our residential treatment, which is up to 1 year that they get to live with us and have all of the services that you saw on that previous slide, every single woman that went through our residential treatment program and completed had a positive child protective service outcome. That means we are reuniting children and moms together. We are getting cases closed. And for our outpatient women, because we have a burgeoning outpatient program, because we don't have the beds to be able to take all of our women into residential treatment, nor do all of our women need that high level of care, of those women that completed the program, 75% of our women, 3 out of 4 women, had their cases closed, positive outcomes, children reunited with moms. So we are doing our small part in the state of North Carolina to bring our mothers back into full recovery. Next slide, please. I needed to put these data in because these were data that were published in the New England Journal of Medicine. It was a randomized controlled trial comparing methadone and buprenorphine during pregnancy. And what we found was that for both medications, regardless of methadone or buprenorphine, for mothers, the outcomes were very similar. Both of these medications, when they're given as a part of comprehensive care and inappropriate doses, it helps maintain drug abstinence in our women, helps give them the foundation to put their lives back together. For our babies, we did have 2 statistically significant outcomes where our buprenorphine-exposed babies required less medication to treat their neonatal abstinence syndrome. They stayed in the hospital a shorter period of time. But the important thing is, what this study shows is that we have 2 medications to treat opioid dependence during pregnancy, not just one anymore. So it gives options. Next slide. So what are my policy recommendations? So I asked my women before I came here, because I said I had this opportunity, and they were like, what? You mean the Senate really cares about this? They couldn't believe it. They were blown away that all of these people would actually come together to talk about them, and in a helpful way and not a punitive way. So number 1 from them is, could we please change the language of addiction? So much of what we use is so incredibly punitive. What's the opposite of a clean urine? A dirty urine, right? It's incredibly stigmatizing. Using addict as a noun is really stigmatizing. Can we please, since it is an illness, a medically understood illness, can we please use medical language to appropriately talk about our disease? Secondly, they said, you gotta tell them we're really good at manipulating doctors. And I think that is something, I mean, our women have grown up, they talk about going with their parents and actually being taught how to talk to the doctor to manipulate them to get the drug that they want, the drug that makes them feel good. So that goes with the policy about mandating education. We need to educate all types of providers that come into contact with our women, law enforcement, dentists. How many dentists give out 30 or 40 Vicodin at any one time for tooth pain? We need to understand not just about misuse of prescription opioids, but about addiction and about addiction treatment, and what are the principles of addiction treatment that work. Every single provider needs, and healthcare and judicial person needs to know about that. The other thing they wanted me to say is that, tell them, Andre, you know what your program does, what Horizon just does, it gives us, when we walk in, we have a pocket full of pills. When we walk out, we have a pocket full of skills. And thank you, Horizons, for letting us use those. So that's from them. In terms of advocacy, absolutely, we need help with payment reform. What the previous panel has already talked about, I just want to underscore, we need patient-centered care. We're all talking about patient-centered care. The payment system has to be patient-centered too. I'm really tired of having 8 hard visits, that I have to meet in a certain period of time. Our women, with the way their life is, it is almost impossible. You are setting the bar way too high, and you're setting them up to fail. So please, can we move to looking at dose of treatment rather than number of days in treatment or number of hard sessions? Housing. When our women leave our program, we have nurtured them and supported them for a full year. Where do they go? Many of our women have no other housing options and they have to go back home, and the chances that they have a job and that they have a safe place to live are really, really low. The women that have success are those that have that aftercare housing. We definitely need a greater continuum of options from the federal level to be able to have adequate housing options for our women, not necessarily just permanent, but transient too. And what else did I want to say? Oh, and then I think the last thing I'm going to say, and then I'll stop, is in our policy, we need to talk about gender. If you look at most of the policies in the United States right now about drug treatment and the drug approach, drug enforcement, where's the gender? Where is gender in it? We have to. If it's just, when it's neutral, women get ignored, children get ignored. So I would challenge everybody to let's look at our policies again, and let's take an eye to look with gender. And with that, I will thank you.
I hope we have time for questions and discussion, because that sounds like a fantastic program. And, it sounds like we're going to hear a lot about what can be done and done well, and what gets in the way of what can be done and done well. Margot Spence is here as president and CEO of First Step Home in Cincinnati, Ohio, and I've heard fantastic things about this program, so I'm very eager.
Okay. Thank you, Tracy. Good morning. I'm Margot Spence, the president and CEO of First Step Home. First of all, I'd like to thank the organizers of the forum. This is absolutely outstanding. And I know Senator Portman is no longer here, but I would especially like to thank him for the outstanding work he's done in Ohio. For years, he's been very supportive of the substance abuse field in the area, particularly of prevention. Thank you for the honor of allowing me to speak with you today about First Step Home and our integrated care for pregnant, opiate-addicted moms program. We are located in Cincinnati, Ohio, and we serve women and women with children, mostly from Hamilton County, but throughout the state of Ohio. All of our homes are located within several blocks, and therefore we're able to provide a campus environment for mom and her children. We provide trauma-informed, non-judgmental, residential, outpatient, and transitional housing. In addition, we have a daycare on site for the children of the moms in treatment. By breaking the cycle of addiction, it is support for the entire family, for the entire community. Our focus is on individual care and respecting the goals of each woman that comes through our doors. As we look at our statistics over the past 2 years, it is evident our clients are getting younger, more are pregnant, and without prenatal care. In addition, they are using opiates at a much younger age. In 2013, the average age of our client was 28 years of age, 63% opiate addicted at entry, 33% were pregnant, 76% of our clients were Caucasian, 22% were African American, 32% no prenatal care. Age at first opiate use was 28, and the number of clients we had was 287 throughout the year. For 2014, the average age of our client, 26.6. 79% are opiate addicted at entry. 45% are pregnant. 88% are Caucasian. 11% African American. 36% no prenatal care upon entry. Age at first use of opiates, 23. The number of clients that we served during the fiscal year 2014, 326 clients. In order to give you an idea of the type of client that comes through our doors and the services that she receives, I'd like to just share with you a quote from one of our clients. This is Lauren's story. When I first walked into First Step Home, I didn't know if I was ready for this type of environment. It was much bigger than the other program that I had attended, but I began to let my guard down. Everyone was caring and inviting. I learned to work with others while helping with meals and chores. The everyday things, like cleaning my room and taking on responsibilities, made me feel important and part of something bigger than myself. As I moved to First Step Home housing, I became excited about becoming a clean mother and caretaker for my family. I was able to work independently and look for a job. I was able to help other new moms deal with their addiction by sharing my life story. First Step Home has impacted my life dramatically. I had lost everything due to my addiction. With the help of First Step Home, I was able to get a job and find a home for my children. I continue to be sober and clean. First Step Home gave me the chance of a lifetime. They never gave up on me. That's something I never had before. I am so grateful for the new life I have been given due to their care and love, end of quote. In order to understand how we arrived at our integrated program for pregnant opiate-addicted women, I would like to share just a short overview of our history. Our program began in 1993 as a drug and alcohol treatment program for women and women with children. Our founders answered the community need of a program that would allow women to bring their children up to the age of 12 with them into treatment. At that time, we treated only alcoholism, addiction to crack cocaine, and marijuana. Since 1993, we have added mental health services and other components to address the needs of women and women with children. Today, we continue to be the only certified treatment program that allows moms to bring their children up to the age of 12 into treatment with them in Hamilton County. Over the past few years, we've experienced a tremendous increase in the number of pregnant opiate-addicted moms in our program needing residential care and needing safe, sober housing upon the completion of the program. As our numbers have increased of pregnant clients, we began to experience early dropout, treatment rates for the moms, low birth rates of the infants, and long stays of infants in neonatal units. In order to enhance our outcomes and ultimately to provide better services for the mothers and also for the babies, we researched more effective treatment modalities and began to meet with treatment providers in the community to coordinate services and to provide more services on site for our clients rather than having them go from one agency to the other. This really involved a lot of communication, enhanced communications with a lot of the providers, because we really felt in order for the client to get well and for the children to be healthy, that it was up to us as providers to work together to create a seamless system of care for our clients. This was a total emphasis on best practice care. Many of our clients receive medicated assisted therapy. They have the option to take methadone, Suboxone, or Subutex along with the counseling therapy. And I think the most important part there, it's an option for that client. The client and her doctor, we take the direction from that rather than having a general rule that our clients can't take this drug or that drug. We have seen tremendous outcomes with our MAT system, which is the medicated assisted therapy for the pregnant moms. And I'd like to just share some of the outcomes. Prior to MAT, the average NICU stay for the baby was 18.6 days. 63% of the babies born were under the 5-pound, 8 ounces standard. Length of stay in treatment was 31 days for the mom, and relapse rate was 62%. With MAT, the average stay for the baby is currently 3.7 days. 97.5% of the babies born to Subutex moms were at proper birth rates. The length of stay for the moms in treatment was 74 days, and the relapse rate for these moms was reduced to 39%. In March of this year, as a result of a grant that we received through the state, we have added a medical director to our services, additional case management services, voc ed services, and child care treatment support. We partner with a hospital, the Good Sam Hospital, for coordinated services, as well as 5 other agencies in Hamilton County. Excuse me. For most of the moms we see, a full continuum of care is essential for recovery. Residential care, transitional housing, outpatient services are just a few of the components needed, supported by professional staff as well as peer mentors, recovery coaches for a mom, and the children to successfully reintegrate into the community. Our goal is to help women and moms recover from addiction, deliver healthy babies, and stabilize their families and become contributing members of our community. Thank you very much.
Thank you, Margot Spence. I was struck by your original mandate and how you've evolved to respond to changes. And we are in a state of emergency in terms of the prescription painkiller, opiate, and heroin crisis, but it's not a new emergency of addiction. We've been here before. And we have an opportunity to respond with evidence-based practice, what works, the critical voice of people directly affected instead of hysteria that caused us to create an emergency of crack babies and so forth. So I'm just very conscious that we are standing on the shoulders of a lot of work that was done before, and we are creating better pathways as we move forward. I'm really happy to introduce the next person because I know her well. Georgia Lerner is the executive director of the Women's Prison Association, a long-standing program in New York and in the country. Women's Prison Association was probably one of the earliest treatment programs because that's where you put crazy and addicted women back in the day. Right. Georgia and I have worked together for quite some time on educating New York policymakers about the benefits and wisdom of alternative to incarceration programs and effective reentry programs, but particularly for women because it seems that the criminal justice system defaults to the male gender, as does addiction services, defaults to male. And things are, that's not right, it doesn't work. And women do have particular and unique needs, and Georgia's gonna talk about an innovative program that WPA is undertaking now that I think is very instructional, very hopeful. Thank you.
I'm honored to be here, and thank you for the opportunity to address you. I'm excited not only because it really is a privilege to be here, but also because I have good news to report about something that is working, and it allows mothers to stay with their children in their own homes, and it's much cheaper than prison. And I will start just with this sort of blanket statement because we are not an addiction treatment program. We work with women who have some involvement with the criminal justice system, but almost all of the women who arrive at the door of WPA, or the Women's Prison Association, get there through drug use. So whether they have a diagnosis of addiction or not, drug use or alcohol use is usually the way that women come to us. So as Tracy said, I'm executive director of the Women's Prison Association. We were founded in 1845 to help women create better lives after incarceration and to improve the conditions of their confinement. And today our work includes working with women at all stages of involvement of the criminal justice continuum, including prevention, which I think is most exciting because I'd love to put ourselves out of business one day. So, for many years, WPA has been sought out by women because we were there for them when they needed to address multiple issues simultaneously. Although our human services systems are generally set up to meet one need, housing or addiction or health care or mental health, nobody experiences these needs in a vacuum. We've often heard from women that they left or failed residential drug treatment, and that was pretty much the default alternative to our incarceration option for any woman or man in New York and many places who was arrested on a drug charge and getting an alternative. But we've heard from many women that they left or failed treatment because they did not want to wait until they had established a strong enough track record of sobriety before they could start planning to see their children. And with the advent of the Adoption and Safe Families Act, women, especially if they had also spent time in prison, ran the real risk of losing custody of their children if they didn't maintain regular contact while their children were in foster care. So women are right in wanting to manage multiple needs at once, but our systems are generally not accommodating. And our clients can count on us to help them address whatever needs they identify, which usually include family law issues, health care, sobriety support, mental health care, housing, employment, and legal sources of income, compliance with criminal justice mandates, the list goes on. And after those nuts and bolts are worked out, we think it's important to help them figure out how to use their leisure time constructively. In the course of our work, we've heard firsthand from clients about their experiences of poverty, trauma, domestic violence, poor educational achievement, and the list of issues that my colleagues have and will discuss today. It became clear to me as I spent more time in jails and prisons, at our former residential alternative to incarceration program, and with women who had been locked up, that we know too much to continue using the same models for responding to crime. I like to start with the question, why do we respond to crime? I think the answer is obvious. It's to maintain public safety and order, right? Isn't that the reason? So what should flow from that is that our responses to unlawful behavior should be designed to restore and maintain public safety and order. But we have seen that prisons and jails are only moderately effective at promoting public safety, and that is limited to removing dangerous actors from the community. We have seen in some neighborhoods that if we remove too many people, even if we think we're just removing the bad actors, crime actually does not decrease. So the idea that we can take the criminals away and make the neighborhood safer is a solution on which we should not rely if our goal is to promote public safety. It seemed to me, from what I saw when we used the opportunities in our residential ATI, to learn from everyday situations, like taking a subway, going to the store, sharing a bedroom, that real life is the best classroom for people to practice pro-social adaptive behaviors and emotional self-regulation. One might say that I am a fanatic believer, and I'm sure my staff say that I'm a fanatic about many things, but that I am a fanatic believer in the instructive value of real life. I insist that WPA staff see where their clients live so that they can understand the view from the client's perspective. Knowing what the world really looks like through a client's window provides essential information for assisting clients in articulating goals, needs, and provides the right environment for us to model and encourage behaviors that promote their successful achievement. Seeing where clients live can also provide a wealth of information about strengths that women may not recognize. Sure, women recognize their problems and see if there are issues with the physical environment, but they often need another set of eyes and significant encouragement to see and use the resources that are nearby. So here's the good news. It's called Justice Home. It's a program that WPA implemented that uses evidence-based practice, and it's consistent with our organizational mission and values, to divert women from incarceration and promote public safety by addressing root causes of crime. The program is cheaper than incarceration. It prevents disruption of families, and it prevents homelessness. It allows women to stay with their children in the community, and it avoids the reentry process entirely, and it promotes public safety by reducing the chances that an individual will commit an additional crime. We've just completed the first year of programming, but it is based on a model that has been used for foster care prevention, and we used that model. We'd operated that model for more than 10 years before we adapted and added to it to make it a criminal justice program. And the first thing we did was use a validated gender-specific risk and needs assessment to identify the criminogenic risks for women facing felony charges and at least 6 months of incarceration. If a woman is interested in addressing her criminogenic risks, the things that are contributing to her criminal behavior, and they are risks that could be constructively addressed in the community. So if they are things like mental illness, healthcare needs, parental stress, unsafe housing, things that we can deal with in the community setting, and she's interested in addressing those things, we will go to the judge and the prosecutor and defense and the whole team and advocate for her to come to our program instead of prison. So far, prosecutors are requiring that women plead guilty, usually to a lesser charge, in order to enter the program, and then the charge is dismissed when a woman completes the program successfully, but we'll come back to that. During her sentence in Justice Home, a woman works on achieving individual goals. She gets regular visits from our staff, probably more regular than she wants. We do drug testing. Staff and the client make periodic visits to court and do written and in-person visits before the judge. Staff visits decrease as clients become more stable, but they vary depending on a client's situation and needs. And staff meet with clients in the community to help improve client familiarity and comfort in a range of aspects of community life. It's one thing to tell somebody that there's a public library and it's free, but going to the public library with someone and walking with someone and helping someone become comfortable and competent in these settings is critical if somebody's going to be able to manage it long term. In addition to the individual service plan goals, clients participate in an evidence-based group intervention for women that takes into account relational theory, women's pathways, and includes cognitive behavioral restructuring, socialization, and other features. The women love this. We weren't sure that they would want to come into the office to participate, and they love it, and they want more and more. Client progress actually can be measured in a scientific way. I don't have to say kind of scientific, it can be measured scientifically. We re-administer the risk and needs assessment after a client's participation over time and can see that criminogenic risks are decreasing. So we know that this intervention is working. We also see that clients are achieving goals that are important to them. And the kinds of goals that clients have, I mean, every person has individual goals, but the kinds of things, so you get an idea, are having a certain period of sobriety, getting and keeping a job for a period of time, possibly having their employment situation improve, achieving educational goals, improving child protective factors in the household, relocating to safer housing, things like that. All of the women who have been engaged in the program for 6 months showed significant reduction in risks from medium or high risk in areas to low, and none of our program participants has been arrested. The concept is simple. When we identify the root causes of criminal involvement, we probably have the best tools for dealing with those causes in the community. And if we can address the root causes, we can reduce the chances that the individual will commit future crimes. We can promote public safety by eliminating the drivers of crime one woman at a time. Now, I know this forum is about addiction, and I have been surprised and fascinated to learn in my years at WPA that addiction is not usually the primary reason that a woman commits crime. Drugs are almost always involved, but antisocial associates, parental stress, active psychosis and other mental illness, prior trauma, abuse in childhood and as an adult, economic and educational deficits, housing safety, poor self-efficacy, and lack of family support almost always emerge as higher risk factors than addiction when we do the risk and needs assessment. So this is all part of what you're hearing about today, but addiction treatment used to be the only thing that we were offering as an alternative to prison. When women have children, parental stress is commonly present, and our home-based program offers an unparalleled opportunity to make a positive difference for the mother and for her children. When we partner with mothers of young children in Justice Home, we can assess and address child safety, developmental milestones, maternal stress, and we can model and reinforce constructive parenting behaviors and promote early childhood and family literacy. Clearly, when a woman goes to prison, we are not able to assist her in managing her household, parenting, and community responsibilities. The skills that a woman can develop in prison cannot be compared to the skills that she can develop, implement, and refine within the actual context of her family's life in the community. So based on what we've learned, I have a couple recommendations. One, we need to expand this home-based evidence-based model to more communities. You can make almost anything work in New York City. We have a great public transportation system. We have lots of treatment beds. We have a lot of alternatives. But this individualized option that's based on the assessed risk and needs of the person who we're dealing with can be taken to a rural environment. It could be taken anywhere. And the other thing I'm pushing for is that we really push to have deferrals of prosecution and not require that everybody take a guilty plea before they're allowed to go into a program, because those convictions, even though they're supposed to be dismissed, have a nasty way of sticking around and having collateral consequences forever and ever. Thank you.
Okay, I got the hurry up sign, but I don't want you to scrimp. No pressure at all. I've been taught every policy issue, no matter how honorable, is connected to money. And we have an opportunity to hear about some innovative strategies for financing, which certainly have come up. So thank you, Pam, for your wisdom.
Well, I'm very glad to have this opportunity, and I do have slides, but I think I'm not going to use them just in light of the time crunch here. But I will have to let you know that at CareSource, I'm going to give you just a real brief overview of what CareSource is a large Medicaid health plan in Ohio, and we also have operations as of last year in Kentucky. We have been around. We celebrated our 25th anniversary this year. Same CEO, same founder, so it's really exciting. We're a nonprofit health plan. To give you a sense of our size and who we serve, we have 1.2 million members that we take and provide care coordination for and cover all kinds of very innovative type programs. Our mission is really, we really do care about what we do each and every day. And the lion's share of our membership is covered family children. That's approximately 950,000 of our membership, and 100,000 plus our age blind and disabled membership. We just launched May 1st our duals demonstration, our Medicaid, Medicare, and I'm still standing here. Let's just say it was a very complex implementation. We'll just leave it at that. But very excited for that, and we do have a small special needs plan, and as I said, our operations in Kentucky. I've been with CareSource. I am a clinician. I'm a nurse, and have been practicing over 32 years, and on the direct care side in home health, hospice, behavioral health, and switched to the payer side about 10 years ago, and I'm very happy that I did that to be able to impact some innovative payments models. With that, though, when I joined CareSource almost 7 years ago, I was introduced to what we call our special investigative unit. And initially, I was a little scared of the people that worked in that unit. They were very much focused on law enforcement, and some carried guns. I thought that was interesting, but there was one nurse on the team, and she was, when I first came to CareSource, she looked at me and said, it was almost like, please get me out of here. So my job is all around clinical design and development of all the health services programs, quality, accreditation, all of the clinical, behavioral, physical, all the programs, all the care and clinical programs. So I could see that I think our special investigative unit didn't really, they saw all these patterns, pharmacies, different providers, all of these patterns, looking at the drugs that were being prescribed, and over 30,000 providers, all kinds of interesting things that providers were doing as well that we were uncovering, pharmacies, medications not being billed, some were being billed. So it was truly something that needed to be sorted out. And so with that, I had this nurse who was extremely competent and very skilled in the area of case management, substance use, behavioral health. And I said, you just come on over to the clinical side. And nobody really knew where to have her report, so I actually had her report directly into me. And at that time, we moved the clinical team and the operations over to us. We have a very, very large case management program. We are required by the state of Ohio. We have very rigorous requirements around case management, so we have a very high-touch, community-based, boots-on-the-ground case management program for both physical and behavioral health. So this fit perfectly. Her focus and her emphasis was great. So what happened is we created a program that was called Care for You. And with that, the state had a very kind of a weak requirement for, they called it member management for substance abuse. And we knew that we had to have some type of emphasis on this, but there were no official guidelines, no lock-in. There was nothing that we were required to do. So we just decided to dive in, and we created the program ourselves. We had to ask for some staff. Our finance staff was at our doorstep wondering what we were doing, because it was very outside of what the normal traditional health plan would be doing. So we did create the Care for You team over about 6 years ago, and it's a multidisciplinary team that has pharmacy, nurses. We work with within 88 counties in Ohio, out there working with all the providers, the community mental health centers, the federally qualified health centers, all of any kind of community provider that we call health partners. And with that, we manage in all of the membership that we identify through our reports and informatics and direct referrals for those members that we know have significant issues with substance use, behavioral health. We have a fully integrated model, so it's within our care management program. We now have that program within a much more structured lock-in program that the state has now mandated for all Medicaid health plans, so that has evolved into that. So we're very, very happy about that. So the Care for You program has done remarkable work. We had a lot of skeptics up front. You know, everyone said, well, it's just never going to work, and I'm not quite sure in a health plan setting how you are going to engage, you know, the members, and how are you going to work with all these different providers, and how is it going to be paid? So, you know, we proved all of them wrong, and some of the slides that I have, I will give kudos to our interns in our informatics department. They came to me with the slides and said, which I'm happy to share, but they worked on the slides for me, and I have highlights from those, very high level, but they were very cute. They said, so how are the slides? And I said, they're perfect. I wouldn't change a thing. So they exist the way they are. The interns did a wonderful job. So first of all, I want to say that just in Ohio, I think we've heard some of the key statistics, but you know, in 2013, you know, there was a significant number of children that we know, children and individuals 12 and older, you know, that have 285,000 were identified that year that, you know, have a substance use diagnosis. At CareSource, we pulled our data in 2013, and we have approximately 16 to 20,000 individuals 12 and older that were assigned what we call our drug abuse diagnosis. So pretty significant number. And 62% of that number were female. And they actually fell in the range of 18 to 39. Over 50% of those that were diagnosed were in treatment, which is great. They weren't using opiates and other than the methadone and Suboxone, so they were in treatment, and you know, we work day in and day out to make sure that we try to get them coordinated within all the communities in Ohio. Our informatics team pulled some information around what were the comorbid other conditions, because you know, we weren't sure with that large number, you know, what were the top physical conditions that were presenting. You know, when you think of covered family children and you think of the age blind and disabled, no surprise that the top diagnosis was low back pain and hypertension and asthma, which I thought was really, really interesting. The top behavioral health diagnoses in our population was anxiety and depression. And one thing that we have learned, and we're always learning, you know, every year that we're out there case managing and trying to make sure that we're touching the appropriate members. This year, our informatics team decided to look at our data with our 1 million members, which is certainly a daunting task of how do you know and what to do for the membership and what do we authorize. You know, obviously, we have to approve services and we case manage and the payment alike. So with that, they did some cluster analysis across our population, and it certainly solidified the need for payment of additional services out there, for us to just continue to advocate for changing those programs. We had 9 personas that we came up with, and across all of the personas, it was interesting that the diagnosis of depression and anxiety were in every persona. That was rampant. So if those are the top behavioral health diagnoses, then other potential substance use issues are there. In addition to that, there was one persona of uncoordinated care, and that was, I of course have them all ingrained in my brain now, but it was persona 6, and it was called uncoordinated care, and there were 54,000 people in that bucket that were just getting care all haphazard, lots of opiate use, so it was pretty clear, and we're working on it right now to really re-engineer how we're looking at who we're actually touching out there in the community. So we are always looking at the complex, high risk, very chronically ill, and we put all these services, and certainly there's quite a few of our consumers that are in that category that have substance use, but we're not focusing on the uncoordinated care as much as the high chronic complex. In addition, the children in some of the other personas and with severe mental illness and all of the other problems. So now we're just stepping back and looking at that from a different perspective to put the services there. One thing the informatics team did pull out was that opiates and drug use and a drug use diagnosis there was over 3 times higher costs than those that had non-opiate use. We also found that neonatal alcohol syndrome, this was in 2013, the cost was 18.5 times more than just a typical newborn, and that was approximately 500 cases that were looked at. And this is really, I have to talk about infant mortality, and I know that everyone in Ohio, our infant mortality rates are terrible, and we have many initiatives out there. I think 49 out of 50 in the states. There was definitely higher infant mortality rates for members using substances within 12 months of delivery. In fact, the infant mortality rate, the rate for substance use was 14.7 per 1,000 as opposed to 9.7 per 1,000 of no substance use. So there's definitely a link there, as we know. The good news is that all of the members that have gone through the Care for You program, and I will tell you that I'll give you this bit of advice from the health plan side and case management side, and that is that I know I can get, as a case manager, I can get anything covered as long as I can justify the medical necessity, show that there are, show the research, show the guideline, and show the cost-benefit analysis. So with that, I'm able to get it covered. So I always say, let's place these members in case management and get the services authorized. And with Care for You and those members that have been in the program, we have, over the years, we've seen a total per member per month cost reduction by 28%, which is about $651 per member per month, which is significant. We have also seen emergency department and inpatient claims decrease by 44% and 32% respectively. And all of those members that have graduated from the Care for You program, their cost and their appropriate utilization and care has continued in their second and third year in the program, so it has been sustained. In closing, our last few comments, I did have a maternal child slide, and in that particular population, it's a full court press on what we offer all the way, all through the antepartum stages of really high intense touch. And then just one of the last slides that the interns pulled was that, we definitely have seen some changes up and down as we've had our pharmacy benefit carved in and carved out and carved back in. It definitely impacts the opiate use trend. And when the benefit is carved in and we're managing it, we see a very nice trend and appropriate use and intervention with the membership. So I did also want to just make mention to that. And those are my comments for today. Thank you.
Okay, we are moving along in our time. You promised to make the slides available, so we're going to figure out how to get those. Okay. I guess we are now at our question and answer. Whoa. Okay. So, a note, especially for those of you with multiple part questions, because I'm going to need to repeat the question into the microphone. So the lady in the back. So the question generally has to do with barriers to medication-assisted treatment for women pregnant and parenting, particularly as they interface with the criminal justice system, drug courts. So if anyone wants to speak to that, if you could touch your mic so the red light is on so it can get recorded.
So thank you for that question. So I do want to say that the National Association for Drug Court Professionals does have an active education campaign. I actually was a part of their most recent conference. So I think that and from that 3-hour discussion, there was a lot of interest and thought. So I think that the conversations are starting to happen. They absolutely need to happen more. I honestly think that the best way to kind of change the generation is to get addiction treatment education into law schools. Because if you learn about the treatment and that treatment works and the principles of treatment and that medications are an appropriate part, I think you're gonna see the culture change. That's my short answer.
Excellent question, because I believe we do experience this in many of our communities, and education, education, education is really the answer. It's kind of hard to argue with good results. So I think when those results can be shared with the different components that you mentioned, I think that we're on the road to more effective treatment for our clients.
Okay, so the question was for Legal Action Center and my colleagues in here, and I can safely say that that is a particular area of interest for us. We have certainly been happy to work with our colleagues at National Association of Pregnant Women and National Advocates for Pregnant Women. Sorry, don't throw a shoe at me. And medication-assisted treatment, particularly some of the barriers to it in the criminal justice system, is a particular focus for us. We are actively working on developing a roadmap that addresses broader addiction issues, but particularly those barriers, and specifically around MAT as it is greeted with some hostility by both Child Protective Services and by the criminal justice system. So that is something that we are actively working on, obviously with ACA and as part of essential health benefits, and also around parity issues. It's become critically important to kind of put out a statement and also work with states in terms of how they're able to incorporate those policies into their state's approach. So there's not a federal response per se, but working state by state is what we're hoping to be most helpful with. I think I'm supposed to cut it off at, So, yes, one more or stop? Stop. Thank you so much, and thank you to the panelists.